Assalamu alaikum. Beta, in this video lecture, I will deliver the lecture on sex cord-stromal tumors, that are the tumors of the ovary. So far, I have delivered so many tumors of ovary, including the surface epithelial tumors, all the surface epithelial tumors of ovary, and at number two, the you know the ovarian tumors that arise from the germ cells, and at number 3 now I will cover the sex cord stromal tumors. So these are the tumors of the ovary that arise from the stroma of the ovary. Okay, so far what have we covered? The tumors of the ovary that arise from the surface epithelium at number 1, ये completely discuss कर लिया हमने part 1-2 वीडियो में. उसके बाद बेटा the tumors of the ovary that arise from the germ cells. Okay, और इसके बाद at number 3 we are now doing the ovarian tumors that actually the sex cord stromal tumors that arise from the stroma of the ovary. So first of all you need to learn that beta, the stroma of the ovary actually derives from the sex cords embryologically. So if this is your ovary and this is the stroma present inside the ovary, this stroma is actually derived from the sex cords embryologically, and the cells which are present in the inside the ovarian stroma, they are actually derived from the undifferentiated gonadal mesenchyme. So there is actually undifferentiated gonadal mesenchyme that give rise to cells which are present in the ovarian stroma. Those cells are granulosa cells, theca cells, Sertoli cells, and the Leydig cells. Obviously, these two cells will not be as much abundant as the granulosa cells and theca cells in the female ovary, because these are significantly the cells of testes. Okay, so making it easy, that this is the ovary and the stroma present inside this ovary is actually derived from the sex cord embryologically, and the cells which are present inside this ovarian stroma, those cells are derived from the undifferentiated gonadal mesenchyme, and those cells are granulosa cells and theca cells, which will be abundant in the female ovary, and the Sertoli cells and Leydig cells may also be present here, but obviously they are not going to be as much abundant. Okay, so because all these cells are present in the ovary, tumor can arise from any of these cells. Okay, beta, look, these tumors can be functional. How? Because granulosa cells and theca cells, if the tumor arises from the granulosa cell or even from the theca cell, so these two cells used to produce estrogen. So if tumor arises from these two cells, there will be lots of estrogen production. And if the tumor arises from the Leydig cells particularly, which normally used to produce androgens like testosterone, so if the tumor arises from the Leydig cells, there will be excessive androgen secretion. Okay, so let's first start with the granulosa cell tumor, and then the Sertoli Leydig cell tumor, and then we will be talking about the tumor arising from the theca cells. So let's first start with the granulosa cell tumor, and then the Sertoli Leydig cell tumor, and then the thecomas, that are the tumors arising from the theca cells. So starting with beta granulosa cell tumors, let me adjust it here. Granulosa cell tumors are of two types on the basis of the age. It can occur in the adults. It can be adult granulosa cell tumor, which is obviously up to 95%. So most common variety is adult granulosa cell tumor. However, the one which is occurring in the younger age is the juvenile granulosa cell tumor. Out of these two, adult granulosa cell tumor and the juvenile granulosa cell tumor, most common is the adult variety. Okay, and adult maybe 2/3 cases are postmenopausal. So 95% is the adult granulosa cell tumor. और adult में भी, what do you mean by adult? कितनी age? 2/3 जो पेशेंट होते हैं बेटा, दे आर पोस्ट मीनोपॉजल. ओके, एंड what is the incidence of the granulosa cell tumor? It makes up 5% of all the ovarian tumors. ओवरी में जितने भी tumors होते हैं उनमें से granulosa cell tumors make up their 5%. Okay, now comes the very important part of this granulosa cell tumor, that is talking about the morphology. Beta. Yeah, how does the granulosa cell tumor appears grossly and under the microscope? That's the important point. Grossly, you come to know better that this granulosa cell tumor involves the single ovary. It is unilateral. It is not bilateral. It involves single ovary, and the size of the granulosa cell tumor vary from the microscopic small foci to large solid and cystic encapsulated mass. So it means it can be very small microscopic foci, or its size can be as large as a big solid cystic encapsulated mass. Okay. And obviously granulosa cell tumor can be hormonally active, because granulosa cells tumors normally they used to produce estrogen. So if they are active hormonally, so if you will come to see the tumor will show yellow coloration to the cut surface due to the intracellular lipids that are the estrogens. Did you understand this point, beta? If your granulosa cell tumor is producing estrogen, which actually produces estrogen because it is the cell which produces estrogen. So if the tumor arises from the granulosa cell tumor, if the tumor arises from the granulosa cell tumor, so there will be estrogen production from that tumor cells. Okay, and that's the reason, because beta estrogen is a lipid, and because the tumor cells are producing this lipid estrogen, so that tumor will be yellowish in color. When you take the tumor out and have a cut section of that tumor, you will see inside that tumor all it is yellow coloration. That is due to the lipid deposition, that is actually the estrogen. And if you see this tumor under the microscope, you will see the tumor cells that are actually the granulosa cells, and they are very much small and cuboidal to polygonal, and they love to grow in the form of cords मतलब रस्सी की फॉर्म में, या नेस्ट जैसे नेस्ट की फॉर्म में, इस तरीके से घोंसले जो होते हैं नेस्ट की फॉर्म में, या फिर स्ट्रैंड्स की फॉर्म में. ठीक है बेटा, आई कैन इवन शो यू द ट्यूमर सेल्स. You can better see in this picture. I hope it is visible. Can you see these cells are very much polygonal? These cells are polygonal, and they all are, look, this is a nest. This is a nest. This is a nest. Okay. So they grow in the form of the nest, or in the form of the strand, or in the form of the cord, and the cells are very much polygonal, and they can be small cuboidal. Okay, so this is how these cells appear under the microscope, the granulosa cells, which are the tumor cells actually. And one more very important diagnostic feature of the granulosa cell tumor under the microscope is the presence of the call axonar bodies. These are the small cystic spaces, gland-like structures. They are filled with the acidophilic material, that is actually the eosinophilic material, and it looks like an immature follicle. Let me take you back to the same picture. Just a second. Let me take you back to the picture. Yeah. Okay. This is the same picture. Just a second. Let's just zoom it in. Just a second. Let's increase the brightness to have a better vision. Okay. Right. There we go. Can you see beta? This is the same picture I showed you, that these are the polygonal cells. Okay, and they are growing in the form of the nests, and they may be cuboidal to polygonal. And one thing is the call axonar bodies that I have to show you. This is the microscopy of your granulosa cell tumor, nothing else. I have to show you the call axonar bodies. What are the call axonar bodies, beta? What are call axonar bodies? These bodies are nothing but actually the small gland-like structures that are filled with the acidophilic material. Can you see this structure, beta? Can you see this structure? This is the call axonar body. This is the call axonar body. Isn't it a small gland-like structure जिसके अंदर आपको ये acidophilic material fill हुआ मिल रहा है? Yeah, these are the call axonar bodies, beta. These are the call axonar bodies, small gland-like structure, और जिसके अंदर ये eosinophilic material deposit है, ठीक है? And it is nothing but looking more like immature follicle जैसे ovary के अंदर होते हैं, ठीक है बेटा? So now let's go a little ahead after this. Yeah, few more points beta from the microscopy. Yeah. Occasionally, there is a thecoma component. We are now discussing the granulosa cell tumor, that is the tumor which is composed of the granulosa cells. But don't forget, occasionally there may be some theca cells. So there may be some theca cells present, there may be some thecal component. Okay, and it's in some cases, beta, what happens that in your tumors, there are granulosa cells obviously, and there may be some theca cells. They may appear as a plumper, like they are very much thicker, and kind of cells which are having ample cytoplasm, abundant cytoplasm. This is the feature of luteinization. Okay, and this is called the luteinized granulosa theca cell tumor. What do I mean by this, beta? Firstly, I told you one thing. Beta, that it is a granulosa cell tumor, but occasionally there may be some theca cells as well, right? And then I told you that these granulosa cells and theca cells present in your tumor, they may be very much plumper, and they can have the cytoplasm which is very much ample, that is abundant cytoplasm. So if you look into each cell, that will be very much healthy cell. Okay, so this is the feature of the luteinization. And if there is a granulosa cell tumor in which granulosa cells and theca cells both are present, and the cells are very much plumper, having the ample cytoplasm, that is now called luteinized granulosa theca cell tumor. Why do we call it luteinized? Because the cells are showing plumper nature, having ample cytoplasm. This is why we call it luteinized. And granulosa cells are present and the theca cells are also present, so therefore we call it luteinized granulosa theca cell tumor, right? And one thing, beta, that is the granulosa cells in your tumor, they do produce the estrogen. So there is obviously one thing to note. If a female develop granulosa cell tumor in her ovary, and granulosa cell tumor produces lots of estrogen, if that girl is prepubertal, if she is having juvenile granulosa cell tumor, तो ज़्यादा estrogen से क्या होगा उसकी बॉडी में? Precocious puberty and sexual development, बहुत ज़्यादा प्रिकॉशियस, एक तो puberty जल्दी आ जाएगी और बहुत ज़्यादा प्रिकॉशियस होगी. ओके, लेकिन फ़र्ज़ करें ये ग्रेनुलोसा सेल ट्यूमर जुवेनाइल नहीं है, एडल्ट है, तो ज़्यादा ईस्ट्रोजन के क्या इफ़ेक्ट्स होंगे बेटा? फिर that ज़्यादा estrogen will have effects on the breast and the endometrium. That ज़्यादा estrogen will cause proliferative breast disease and endometrial hyperplasia and carcinoma in up to 10 to 15% of the women. So lots of estrogen is being produced from the granulosa cell tumor, and if you are an adult woman, then this estrogen will have effect on your breast, producing proliferative breast disease, and will have effects on the endometrium, causing proliferation of the endometrium, leading to the hyperplasia and matlab carcinoma. Okay, right. Occasionally this tumor, very occasionally this tumor can produce androgen. I don't know literally, and it is not even written in your text, that is Robbins. But in all the lectures I do used to mention each and every single word from your textbook, Robbins. So but yeah, there we go, that occasionally this tumor can produce androgens. So if it is producing androgens, so there may be some features of the masculinization in the females. Okay, I hope you are clear so far, beta, with the granulosa cell tumor. Granulosa cell tumors show recurrences within the pelvis and abdomen, and recurrences may appear 10 to 20 years after removing the original tumor. If a girl develops a granulosa cell tumor in her ovary, and she gets treated with removal of the tumor, it is possible that after 10 to 20 years there may be the recurrence of the tumor within the pelvis and the abdomen. So by the way, if you treat this tumor, if you remove this tumor, there is a 10-year survival rate up to 85%. Okay, what are the serum markers of this tumor, granulosa cell tumor, to make the diagnosis? But the very important marker is inhibin. Inhibin is the hormone which is actually produced by the granulosa cell tumor. Granulosa cell tumor, they do produce estrogen, I know, but do you think estrogen is a very good marker to diagnose the granulosa cell tumor? It is never a good diagnostic marker, because estrogen normally used to be in your body. So estrogen is not something that can be diagnostic. Inhibin is something that can be very much diagnostic, because if somebody develops granulosa cell tumor, then in her body, in the tissues, in the serum, levels of inhibin will be elevated. Okay, now at the last beta, I will mention what are the underlying mutations that are responsible for the development of the granulosa cell tumor. In up to 97% of the adult granulosa cell tumor, there is mutation in what gene? FOXL2 gene. FOXL2 gene, which normally encodes the transcription factor which is important for the granulosa cell development. नॉर्मली व्हाट इज़ द फंक्शन ऑफ दिस जीन? टू प्रोड्यूस सम ट्रांसक्रिप्शन फैक्टर्स जो कि क्या कराते हैं, ग्रेनुलोसा सेल्स की डेवलपमेंट कराते हैं। जब इस जीन में म्यूटेशन हो जाएगी बेटा, तो ये जीन क्या करेगा, ज़्यादा ट्रांसक्रिप्शन फैक्टर बनाएगा और वो ज़्यादा ट्रांसक्रिप्शन फैक्टर ग्रेनुलोसा सेल्स की डेवलपमेंट को ज़्यादा बढ़ा देगा, जिसकी वजह से ट्यूमर फॉर्मेशन हो जाएगी। आई होप यू आर क्लियर विथ दिस बेटा, राइट? ओके, after the granulosa cell tumor, I have another sex cord-stromal tumor, that is Sertoli-Leydig cell tumor. Sertoli-Leydig cell tumor. Okay, so yeah, let me tell you about this Sertoli-Leydig cell tumor. Right, beta. The Sertoli-Leydig cell tumor, obviously it has to be functional. By the way, these cells, especially the Leydig cells, they used to produce testosterone androgens. So if in the ovary you develop the Sertoli-Leydig cell tumor, that tumor will surely produce lots of androgen, because these cells normally used to produce androgen. So if you develop tumor in these cells will then produce androgen in very much excessive quantities. Okay, so if in a female there is increased androgen production, what you guys think is going to happen is obviously there will be masculinization and defeminization. So what features will you see? There will be voice changes. Voice थोड़ी भारी हो जाएगी, मर्दाना जिसको आवाज़ कहें. Hypertrophy of the clitoris, breast atrophy. You can see all are these kind of male features. Amenorrhea, kind of sterility. Early there is loss of hairs, but later you come to see there is hirsutism. Loss of hairs in the male pattern, like male baldness. लेकिन बाद में हिर्सुटिज्म होती है, जैसे कि चेस्ट पे हेयर्स का आना, ओके, एंड एक्सट्रीमिटीज़ पे हेयर्स का आना, फेस पे बियर्ड का आना. ओके, सो दीज आर द फीचर्स यू कैन कम टू सी in this particular tumor. At what age does this develop? Women of all ages can develop this tumor, but the peak incidence is in the second to third decade. Second to third decade, right? Women of all ages can develop this tumor, by the way, but the peak incidence is second to third decade. What are the underlying mutations, beta, that are responsible for the development of this tumor? Can you revise with me, beta? What were the mutations involved in the granulosa cell tumor? Those were I think it was the FOXL1 gene. Okay, but here in case of the Sertoli-Leydig cell tumor, the underlying mutations are in what gene? Dicer1 gene. Dicer1 gene is mutated, which normally uses to produce, encodes an endonuclease enzyme, which is essential for proper processing of microRNAs. Normally, what is the function of Dicer1? The normal function of the Dicer1 is better to produce endonuclease enzyme. And what does this endonuclease enzyme do? Proper processing of microRNAs. If this gene is mutated, there will be no production of endonuclease. And if the endonuclease is not being produced, you think there will be proper processing of microRNAs? No. If there is no proper processing of microRNAs, so this may be a reason behind the development of Sertoli-Leydig cell tumor development. Now it's the time to discuss better the morphology of the Sertoli-Leydig cell tumor, the gross appearance and the appearance of the tumor under the microscope as well. Okay, grossly this tumor beta is unilateral, that it means it involves a single ovary, and interestingly it may resemble the granulosa cell tumor grossly. Okay, and if you produce the cut section of this tumor, then you will see this tumor is very much solid, and the color is varying from, it can be gray to golden brown, right? This is the gross appearance of your tumor, Sertoli-Leydig cell tumor. Under microscope, you will see beta, the tumor cells are very much well differentiated, and they show, under the microscope, the Sertoli-Leydig cell tumor may show three varieties: well differentiated, intermediate form, and poorly differentiated form. What did I say, beta? Do revise it with me. What did I say? That under the microscope, Sertoli-Leydig cell tumor may show three patterns. It may be well differentiated, intermediate form, or poorly differentiated form of Sertoli-Leydig cell tumor. If the Sertoli-Leydig cell tumor is well differentiated, then how does it appear under the microscope? It will show some tubules which are composed of the Sertoli cells, and there is a stroma. within which the Leydig cells are interspersed. Let me show you beta this what I'm trying to say. Yeah, I hope it is visible. Okay, I hope it is visible. Yeah. Okay, now here you can see beta that this is the microscopic picture of your Sertoli Leydig cell tumor, and it is well differentiated variety. It is well differentiated variety. Can you see these are the tubules? Can you see these tubules beta? Can you see these tubules? These tubules are lined by tubules composed of Sertoli cells, and you can see, other than these tubules, these two tubules are separated by this stroma, and this stroma is actually filled by Leydig cells. Okay, so if this is the well differentiated Sertoli Leydig cell tumor, if this is the well differentiated Sertoli Leydig cell tumor, then you will see beta that these are the tubules which are lined by the Sertoli cells, and in between the tubules is the stroma within which what cells are interspersed? Leydig cells. Okay, I hope you are clear with this beta. Yeah, when you compare the well differentiated tumor with the intermediate form, then in case of intermediate form shows only outlines of the tubules and large eosinophilic Leydig cells. Did you find the difference between the well differentiated and the intermediate variety? Well differentiated के अंदर tubules थी that were composed of Sertoli cells, और stroma था जिसके अंदर Leydig cells थे. Intermediate form shows only the outlines of the tubules, and there are no Sertoli cells which are lining the tubules. Okay, by the way, Leydig cells are also present in this. So difference is इसमें tubules हैं, इसमें भी tubules हैं. इसमें tubules lined by Sertoli cells, इसमें tubules not lined by Sertoli cells. इसमें stroma के अंदर Leydig cells हैं, इसमें भी Leydig cells हैं. At number 3 is beta poorly differentiated variety. Let me quickly show you. Yeah, poorly differentiated variety shows the sarcomatous pattern. ओके, जिसके अंदर एपिथेलियल सेल्स आपको मिलेंगे डिपॉजिटेड और Leydig सेल्स में बी एब्सेंट. सो दिस इज द वैरायटी वेयर दिस इज पुअरली डिफरेंशिएटेड, वेरी मच पुअरली डिफरेंशिएटेड. इतना पुअर के इसमें आपके ट्यूमर का नाम क्या है बेटा? सर्टोली Leydig सेल ट्यूमर नाम है ना, सर्टोली Leydig सेल ट्यूमर. तो उसमें सर्टोली और Leydig सेल्स दिखने चाहिए, लेकिन ये इतना पुअरली डिफरेंशिएटेड ट्यूमर है कि इसके अंदर आपको ना सर्टोली सेल दिखेंगे ना Leydig सेल दिखेंगे. ठीक है, Leydig सेल में भी एब्सेंट, सर्टोली सेल्स आर नॉट देयर आर जस्ट disorderly deposition of the epithelial cells with the sarcomatous pattern, right? And don't forget beta, after these there may be some heterogeneous elements present inside this Sertoli Leydig cell tumor. Inside that tumor there may be some mucinous glands present, some bony cells present, some cartilaginous chondrocytes may be present. Okay, so this is the feature very importantly you have to keep in the mind. Last thing about the Sertoli Leydig cell tumor is the incidence of the recurrence or metastasis is less than 5%, and that's a good news. I think it's just less than 5%. That's all about the Sertoli Leydig cell tumor beta. That's all about the Sertoli Leydig cell tumor. Now come to few more sex cord-stromal tumors. Few more में सबसे पहले हम करेंगे फाइब्रोमा थीकोमा. ये दो अलग नहीं है, ये एक, ये फाइब्रोमा थीकोमा. ओके, या सो हमने अभी तक कौन से सेक्स cord-stromal ट्यूमर किए बेटा? एक हमने किया है सबसे पहले ग्रेनुलोसा सेल ट्यूमर, उसके बाद Sertoli Leydig सेल ट्यूमर. एट नंबर 3 वी आर डूइंग सम अदर सेक्स cord-stromal ट्यूमर्स लाइक फाइब्रोमा थीकोमा. दे आल्सो ऑब्वियसली अराइज फ्रॉम द ओवेरियन स्ट्रोमा. लुक, अगर ट्यूमर ओवरी के अंदर स्ट्रोमा के अंदर मौजूद फाइब्रोब्लास्ट में से ओरिजिनेट हो तो उसको फाइब्रोमा कहेंगे. क्या कहा मैंने? अगर ट्यूमर ओवरी के अंदर मौजूद स्ट्रोमा के अंदर मौजूद फाइब्रोब्लास्ट में से ओरिजिनेट हो तो उसको फाइब्रोमा कहेंगे. अगर फाइब्रोब्लास्ट की जगह ट्यूमर ओरिजिनेट हो आपके थीका सेल्स में से, थीका सेल्स आर बाय द वे द प्लम्प स्पिंडल सेल्स हैविंग लिपिड ड्रॉपलेट्स, तो अगर थीका सेल्स में से ओरिजिनेट हो तो उसको थीकोमा कहेंगे. हाँ, अगर दोनों ट्यूमर एक साथ हों तो उसको फाइब्रोथीकोमा कहेंगे. ठीक है, एंड बाय द वे दीज फाइब्रोमा थीकोमा दे मेकअप द 4% ऑफ द ऑल ओवेरियन ट्यूमर्स. दे मेकअप द 4% ऑफ द ऑल ओवेरियन ट्यूमर्स. प्योर थीकोमास आर रेयर, बट रिमेंबर दे आर एक्टिव हार्मोनली. अगर किसी को सिर्फ थीकोमा हो जाता है, फाइब्रोमा नहीं होता, सिर्फ थीकोमा होता है, तो ये रेयर है, लेकिन थिकोमा हार्मोनली एक्टिव होता है, एस्ट्रोजन प्रोड्यूस करता है। फाइब्रोमा होना थोड़ा कॉमन है एज़ कम्पेयर टू थीकोमा। प्योर फाइब्रोमा, सिर्फ फाइब्रोमा होना थोड़ा कॉमन है एज़ कम्पेयर टू प्योर थीकोमा, लेकिन इट इज़ हार्मोनली इनएक्टिव, क्योंकि फाइब्रोब्लास्ट दे आर नॉट प्रोड्यूसिंग एनी हार्मोन एट ऑल. If they are being, like concurrently, if they are presenting together, they are called fibrothecoma. Okay, so let's first talk about the fibroma. Okay, and then the thecoma. Beta, fibroma, starting with fibroma, it is unilateral in 90% cases. It is unilateral, appears in one ovary only. And if you perform the morphology, then how does it appear grossly and how does it appear under the microscope? Grossly, it is very much solid and hard tumor, and it is spherical or slightly lobulated in the appearance. This tumor is covered by a capsule, that is why we call it encapsulated, and by color it is gray white mass. Okay, and it is covered by the glistening ovarian serosa. So if this is the tumor, this is the tumor fibroma. Okay, so it is very much solid or hard. It is solid and hard. It is spherical, and it is covered by a capsule, and above the capsule you will find this nice little serosa, which is very much chamakdar, very much glistening. Okay, after gross appearance, there is the microscopic appearance. Microscopically, this tumor is composed of obviously fibroblast, well differentiated fibroblast, and in between the fibroblast there may be some collagenous stroma and the focal areas of thecal differentiation. So if this is your tumor, then these are the cells. What are these cells? These are fibroblast, obviously, because this is a fibroma, and in between the fibroblast you will see some stroma. This stroma is actually the collagenous stroma, and somewhere you may also find some thecal cells. Okay, so this is the, yeah, let's go a little ahead. This was the beta morphology, the gross and the microscopic appearance of the fibroma. Now comes the clinical picture of the fibroma. Clinically, how does it present, beta? There is obviously mass in the pelvis, in the region of the ovaries, and sometimes there may be pain in the pelvis, and fibroma presents with beta two very important curious associations of fibroma. Yeah, one is the ascites, one is another. I'll tell you surely, but first talk about the ascites. What did I say, beta? Fibroma is associated with two curious associations. Fibroma may present with ascites in 40% cases. And if somebody develops the fibroma and he presents with ascites, so in that case the fibroma measures more than 6 centimeter diameter, and along with ascites there is hydrothorax, uncommonly, but it is there. That is fluid water accumulation in the pleural cavity, so usually on the right side, on the right lung. Okay, so if there is the ovarica tumor, that is the fibroma, and there is hydrothorax and ascites, these three things together is called Meeks syndrome. So yeah, if you develop the fibroma in your ovary, it is possible that you may come up with ascites and uncommonly hydrothorax. So if there is ovarian tumor fibroma, you may come up with the hydrothorax and ascites. These three together called Meeks syndrome. I told you two curious associations I will tell. One curious association is this. Another curious association is basal cell nevus syndrome. If you have ovarian fibroma, you may come up with the basal cell nevus syndrome as well. This is a syndrome in which multiple pathologies occur, in which one of which is basal cell carcinoma of the skin. Okay, beta, fibroma, thecoma, fibrothecoma, they are benign, right? And rarely कोई malignant होता है, rarely fibrosarcoma होता है. ठीक है बेटा? So now we are done with fibroma, and now right after the fibroma I'll be discussing about another sex cord-stromal tumor, that is the pregnancy luteoma. Pregnancy luteoma, beta. Pregnancy luteoma, it actually, obviously a sex cord-stromal tumor. It develops in the ovary, but remember, it develops in the ovary during pregnancy. Okay, and it's not really common. It is actually a rare tumor, and when it develops in the ovary, it closely resembles the corpus luteum of the pregnancy. If this is your ovary, if this is the ovary and this is the corpus luteum of the pregnancy, that's a very important structure, and this is the pregnancy luteoma. So because this is the pregnancy luteoma and this is the corpus luteum of the ovary, so this pregnancy luteoma, that is the sex cord-stromal tumor, it actually resembles very much to the corpus luteum of the ovary. Okay, of the in the pregnancy obviously. And you know beta, if this pregnancy luteoma develops in the ovary, if this pregnancy luteoma develops in the ovary during pregnancy, it will produce viralization of the pregnant mother and their female infant. Viralization that refers to it's kind of masculinization, having more male characteristics. Okay, so pregnancy luteoma, in short, it's a rare tumor, my son, occurs in the ovary during pregnancy, and it resembles the corpus luteum of the pregnancy, and it will produce viralization of not only the pregnant mother but of the female infant as well. Right. Okay. Right after the pregnancy luteoma, right after the pregnancy luteoma is another sex cord-stromal tumor, that is Hylas cell tumor. It is a pure Leydig cell tumor. Previously, we discussed the Sertoli Leydig cell tumor at number 2, but this Hylas cell tumor, it is a pure Leydig cell tumor. It derives from the cluster of the polygonal cells around the hilar vessels. If these are, let's suppose, the hilar vessels, if these are, let's suppose, hilar vessels in the ovary, okay, and around these hilar vessels, there are some polygonal cells. These are none other than your Leydig cells. Okay, so these are the hilar vessels in your ovary, near the hilum. So around these hilar vessels, these are the polygonal cells, clusters of the polygonal cells. These are the Leydig cells from which this Hylas cell tumor arise. It's also a rare tumor. It is unilateral, that is affecting the single ovary, and it is obviously composed of the lipin-laden Leydig cells. It is actually a Leydig cell tumor, so it has to be composed of Leydig cells. The Leydig cells show the disc-like borders. Okay, disc-like borders. If even I can show you the disc-like borders. Here, there we go with this. These are the cells. These are the characteristic Leydig cells of the pure Leydig cell tumor. These are the characteristic Leydig cell tumors, Leydig cells of the Leydig cell tumor. You can say these are more distic surfaces, distic borders it has. And beta, inside the cells, you will find some very important structure, the characteristic cytoplasmic structure called Renke crystalloid. This is a Leydig cell in the Leydig cell tumor. And inside the cytoplasm, you will come to find a very important characteristic feature, that is a Renke crystalloid. Okay. Even I can show you the Renke crystalloid with a much better picture. You can see this, this large is the cell. Even you can take this cell, okay. Can you see the purple color inside that? That is due to the Renke crystalloids, okay. Right. Okay, if you develop this tumor, that is a pure Leydig tumor, Hylas cell tumor also called, it will obviously produce lots of androgens, and because of that androgens, there will be masculinization in the women. So masculinization in the women, obviously, because there is lots of androgens, so there will be masculinization that will come up with the hirsutism, voice changes, and the clitoral hypertrophy. And remember, these changes are milder than those in Sertoli Leydig cell tumor. At the number 2 in this video, I delivered the Sertoli Leydig cell tumor, in which I told you, beta, there are some masculinization features, and as compared to that Sertoli Leydig cell tumor, here are, even you can see, there are some masculinizing features. But in which tumor there are more severe, more masculinization? It is in case of Sertoli Leydig cell tumor as compared to the Hylas cell tumor. Okay, Hylas cell tumor is almost always benign, and its treatment is surgical excision. Gonadoblastoma, beta. Gonadoblastoma is the last sex cord stromal tumor we are now doing. By the way, it is also uncommon rare tumor composed of the germ cells and some sex cord stroma derivatives, some derivatives of sex cord stroma and germ cells. This is the composition of the gonadoblastoma. It does not occur commonly in all the females, but it occur in the females with abnormal sexual development and in gonads of indeterminate nature. If the gonads are not well differentiated, if there is a female with a gonad and it is not differentiated, that it is a complete ovary or not, so that is where gonadoblastoma develops, right? 80% are the phenotypic females and 20% are the phenotypic males with the undescended testes or female internal secondary organs. So 80% of this gonadoblastoma develops in individuals who are phenotypically actually females, but in 20%, they are phenotypically males, but make sure they have undescended testes or internal secondary organs are of female. Okay, phenotypically they are male, but internal organs, secondary organs, they are of female. Don't forget beta, this gonadoblastoma, it coexistent with dysgerminoma in 50% cases. So dysgerminoma is what kind of tumor, beta? Can you let me know, beta? It's a quiz for you. Dysgerminoma, don't forget, it is a tumor of ovary, obviously, but what variety of tumor it is? It is a germ cell tumor. Okay, dysgerminoma. So dysgerminoma and gonadoblastoma, they too can coexist in 50% cases. The prognosis of this tumor is excellent if tumor is completely excised. And that's all about the gonadoblastoma and all about beta sex cord-stromal tumors and all about the tumors of the ovary. And we are finally done with the tumors of ovary. That's all about this lecture, beta. Hope you got the concepts. If you did, you can appreciate me by liking to the video, beta, subscribing the channel. Thank you so much. Class dismissed.